Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta, medical editor at MIMS Learning, and with me in the studio today is deputy editor Rhiannon.
Hello.
Today, let's talk about bloating and irritable bowel syndrome, or IBS. About 15% of the population has IBS. Also, since bloating is one of the several symptoms characteristic of IBS, we'll also be covering it today. Bloating is a common feature of not just IBS, but a spectrum of different gastrointestinal or GI disorders. There's a lot to talk about, so let's dive right into it. IBS was once called a functional gastrointestinal disorder, but do you know why the term is associated with some stigma, Rhiannon?
No, can you tell me more about it?
So the word functional has been used historically to describe chronic or recurrent symptoms that cannot be readily explained by structural disease. The word functional is both non-specific and stigmatizing for being viewed as all in the head or psychiatric.
Right, so are we moving away from using that term now?
Yes, we are. And what used to be called functional gastrointestinal disorders has been renamed to disorders of gut-brain interactions now.
Okay, so that seems to acknowledge the complexity of the conditions and indicates that it's a real physiological process. So what are some of the symptoms of IBS?
Symptoms include recurrent abdominal pain or discomfort that's associated with a change in stool frequency or form. Symptoms are non-specific and often overlap with those of organic GI conditions like celiac, IBD, microscopic colitis or bile acid diarrhea, gynecological conditions like ovarian cancer or endometriosis, or sometimes conditions such as thyroid disorders.
So that's quite a broad list. How do clinicians diagnose IBS then when the symptoms are so non-specific?
So according to NICE, IBS can be diagnosed if a person has abdominal pain, relieved by defecation or associated with altered bowel frequency or stool form for at least 6 months, and at least 2 of the following additional symptoms need to be present for diagnosis: urgency, bloating, symptoms made worse after eating, or passing mucus. The Rome 4 criteria requires there to be pain at least 1 day a week for the past 3 months, and the pain should fulfill 2 of 3 criteria. It should be related to the defecation, associated with a change of stool frequency, or a change in appearance of stool.
So IBS also has several subtypes, and clinicians will need to determine which type of IBS it is, because that's an important next step to determining management. So there are 4 subtypes. The predominant subtype is mixed IBS or IBS-M, followed by diarrhea predominant IBS or IBS-D, constipation predominant IBS or IBS-C, and unclassified IBS or IBS-U. And the names are fairly self-explanatory.
Neither of those 2 criteria I described earlier have a positive diagnostic test. So what tests should a GP order?
Well, patients with suspected IBS should have a full blood count, C-reactive protein or erythrocyte sedimentation rate, and celiac serology. And a fecal calprotectin should be used for patients under the age of 45 to exclude IBD. But you're right, there isn't a positive diagnostic test for IBS, so establishing a diagnosis requires eliminating alternative diagnoses and using a trial of treatment to confirm the suspected diagnosis. So should we talk about red flags in patients who are presenting with symptoms of IBS for the first time that might indicate that there's actually a different diagnosis to consider?
Yeah, so patients who present with symptoms of IBS for the first time should be assessed for red flag symptoms of colorectal cancer, such as unexplained weight loss and rectal bleeding. In women over 50 with new symptoms, clinicians should consider ovarian cancer and check a CA125 or get an ultrasound.
Okay, so what would be the first line management then for someone who has been diagnosed with IBS?
Management is a stepwise and symptom-focused approach. The first step includes dietary and lifestyle advice for symptom management, having regular meals, hydration, at least 8 cups of fluid daily, and exercise. Patients should be advised to restrict tea and coffee to 3 cups or 2 mugs a day. Soluble fiber is an effective treatment for pain and other symptoms. Patients should be advised to stay clear of insoluble fiber like wheat bran, which can worsen symptoms. Patients who wish to try probiotics can be advised to go on a 4 to 12 week trial. The MIMS Learning module on IBS by Dr. Kevin Barrett lists pharmacotherapeutic options, but Dr. Barrett notes that these should be used alongside dietary and lifestyle advice, and doses should be prescribed with a view to avoiding side effects. Effective treatments include loperamide for IBS-D, antispasmodics and peppermint oil for abdominal pain, and laxatives such as polyethylene glycol. The use of lactulose should be discouraged in IBS-C, as it is a FODMAP that can make symptoms worse.
Okay, so that's interesting. Thanks for that. That was first line management, but if these approaches don't work, clinicians can move on to second line options, which include low FODMAP diet, although this would be supervised by a trained dietitian. So as a reminder, a low FODMAP diet is a diet low in fermentable oligosaccharides, disaccharides and monosaccharides, and polyols. Pharmacological treatment options include a low-dose tricyclic antidepressant, or TCA, such as 5 to 10 milligrams of amitriptyline at night, which can help with persistent pain. If constipation is the main issue and hasn't responded to laxatives for a year, linaclotide is an option.
There are some cases of IBS that persist and do not respond to any of these options after 12 months. This is called refractory IBS. These cases will need to be referred for third-line interventions, which include psychological interventions such as cognitive behavioral therapy, gut-directed hypnotherapy, and psychological therapy. Rhiannon, shall we talk about some of the other conditions that present with bloating as a symptom?
So we have a module on this subject by Dr. Mohsin Butt and Professor Kasim Aziz, which goes into differential diagnoses for bloating, and there are a lot of possibilities. Firstly, it could be SIBO, or small intestinal bacterial overgrowth. SIBO is broadly defined as the presence of excessive numbers of bacteria in the small bowel, causing gastrointestinal symptoms. Some of the most common symptoms in patients with SIBO include abdominal pain, bloating, gas, distension, flatulence, and diarrhoea. So you can see why this condition is considered a mimic of IBS. So many of the symptoms overlap. And there is evidence to suggest that up to 78% of patients with IBS may have comorbid SIBO. And the module also has a very useful printable quick reference guide of the features and diagnostic tests and management of conditions that cause bloating.
Similarly, the symptoms of bile acid malabsorption overlap with diarrhea predominant IBS. That is, diarrhea, urgency, nocturnal defecation, excessive flatulence, abdominal pain, and fecal incontinence. There's data to suggest that about 25% of people with IBS-D symptoms meet the criteria for bile acid malabsorption.
And we should talk about eating disorders too. In fact, disordered eating is seen in 13 to 55% of adults with gastrointestinal disorders, and it's thought to be higher in people with disorders of gut-brain interactions than in those with organic gastrointestinal disorders.
Yeah, that's really interesting. I would have thought it the other way around, that is, people with eating disorders develop gastrointestinal disorders. I looked into it and it seems there is a bidirectional link between the two, and that GI disorders might be a risk factor for developing eating disorders.
Yeah, so in the learning module, the authors say that elevated fullness and bloating are both associated with increased purging, restrictive eating behaviours, and the likelihood of having an eating disorder. And people with eating disorders, such as avoidant restrictive food intake disorder, or ARFID, or bulimia, may experience bloating because of abnormal gut motility. And pelvic floor dysfunction is also an important factor, interestingly, that contributes to the distension seen in patients with eating disorders. So this is a good reminder for clinicians to ask patients broader questions beyond just their gut symptoms.
Once these diagnoses are made, what would be the next steps?
Well, for the mimics that we discussed, so SIBO and bile acid malabsorption, the management is quite specific. The focus for SIBO is on fermentable products, and there have been studies around the use of antibiotics like rifaximin, but the authors of the learning module on bloating caution that antibiotics have to be used judiciously.
For bile acid malabsorption, which can masquerade as IBS-D, 3 bile acid sequestrants are available: cholestyramine, cholestyramine, and cholesevelam. Patients should take these with meals to bind those free acids and prevent that increased colonic motility and secretion.
And for eating disorders, management calls for a biopsychosocial approach. And we have some learning modules on eating disorders on mimslearning.co.uk, and we've discussed this in previous episodes of the podcast as well, which we'll link to in the show notes.
Moving on from eating disorders to other causes of bloating. There are several functional disorders that cause this symptom. But before we get into it, let's clarify where the functional label fits. We did say earlier in the episode that there is a conscious move away from the word functional because of the stigma it can carry. That said, there are still numerous conditions that are still named functional.
Yeah, so tell us more about those, Sangeeta.
So, for instance, functional diarrhea is diagnosed when someone has loose or watery stools but does not fulfill any of the other criteria to have IBS. Patients with functional diarrhea and no alarm features should undergo limited blood testing, including a full blood count, a C-reactive protein, and serological testing to rule out celiac disease. As in IBS, fecal calprotectin levels should be tested to rule out IBD, and patients with red flag symptoms should be screened for colorectal cancer. Management here often centers on loperamide as an antidiarrheal agent.
Can probiotics be used for functional diarrhea?
So at present, there is no evidence that probiotics would improve symptoms in these patients. Another one is functional constipation, where individuals don't fulfill IBS criteria because pain isn't the major determinant. Management for this includes fiber, insoluble fiber, but funnily enough, bloating, distension, and flatulence are some of the adverse effects of increased dietary fiber.
Yeah, so a bit of a catch-22 then.
Yeah, exactly. So for these patients, clinicians can also prescribe osmotic laxatives like polyethylene glycol or 5-HT4 agonists. When the constipation is chronic, the osmotic laxatives, polyethylene glycol and lactulose, and the stimulant laxatives, sodium picosulfate and bisacodyl, have been shown to be effective. What about when bloating is the only symptom?
So that is called functional bloating and is diagnosed when there's recurrent bloating or distension at least one day a week. And functional bloating is only diagnosed if the patient doesn't meet the criteria for IBS, constipation or diarrhea. Management of functional bloating involves identifying specific food triggers, such as artificial sweeteners containing sorbitol or mannitol, which can promote intestinal gas production. And there's no uniformly accepted antibiotic treatment for patients with functional bloating. And that said, rifaximin has been the most studied antibiotic for bloating. But what other functional GI conditions are diagnosed by elimination, Sangeeta?
One other GI condition often seen alongside bloating is functional dyspepsia. This can only be diagnosed when there is no evidence of structural disease on an upper GI endoscopy to explain symptoms like bothersome epigastric pain or burning, postprandial fullness, and early satiation. According to the Rome 4 system, these criteria should be present for 3 months, and the symptoms should have begun at least 6 months before the diagnosis. There are 2 subtypes of functional dyspepsia, epigastric pain syndrome and postprandial distress syndrome. Bloating is reported by up to 85% of patients with the postprandial distress subtype of dyspepsia. Let's talk about another similar condition, gastroparesis, which is characterized by delayed gastric emptying in the absence of a mechanical obstruction and epigastric symptoms like nausea, vomiting, postprandial fullness, and epigastric pain.
That sounds rather similar to functional dyspepsia.
Yeah, it is rather challenging to distinguish between the two based on symptoms alone, and the jury is still out whether gastroparesis is its own condition or whether it's linked to dyspepsia. But because delayed gastric emptying is the defining feature of gastroparesis, an abnormal gastric emptying test is mandatory to diagnose the condition. The risk factors for gastroparesis include diabetes, partial gastric resection, bariatric surgery, some neurological disorders, and some drugs such as opioids.
Patients with functional dyspepsia should be advised to perform regular aerobic exercise. Proton pump inhibitors are effective treatments for functional dyspepsia. Tricyclic antidepressants and selective serotonin reuptake inhibitors can be used as second-line treatments for functional dyspepsia as well. On the other hand, PPIs and antiemetic therapies are not recommended first-line treatments for gastroparesis. Dopamine 2 agonists and 5-HT4 agonists are effective therapies for gastroparesis. There is another classic cause of bloating, and that's lactose intolerance. Given that 3/4 of the world's population will eventually lose the ability to digest lactose, it's a fairly common condition. The symptoms associated with lactose intolerance vary considerably. Typically, abdominal pain, distension, flatus, and diarrhea are the dominant symptoms, reported following the consumption of lactose-containing products. The management of lactose intolerance requires a dietary exclusion of lactose. In the case of patients who cannot eliminate lactose from their diet completely, then lactase supplements might be used.
And on the subject of intolerances, celiac disease and gluten sensitivity are potential causes of bloating as well. Celiac disease is an immune-mediated inflammatory enteropathy triggered by gluten exposure. Similar to lactose intolerance, signs and symptoms of celiac disease vary significantly across individuals, but typically include bloating, diarrhea, abdominal pain, constipation, vomiting, and weight loss. Though the symptoms of gluten sensitivity are similar to those of celiac, it's not an immune-mediated condition. Around 70% of people with non-celiac gluten sensitivity report bloating as a symptom. So, what have we learned today? First, IBS is a complex disorder of gut-brain interaction affecting 15% of people and is diagnosed clinically based on NICE or Rome-4 criteria, but requires basic bloods, FBC, CRP and celiac serology, and screening of red flag symptoms to exclude cancer. Second, management of IBS follows stepwise escalation, starting with lifestyle and dietary advice, moving to second-line therapies like low-dose tricyclic antidepressants or a supervised low FODMAP diet, with psychological therapy for refractory cases. And finally, bloating is multifactorial and requires a broad clinical lens to identify contributors and can include SIBO, bile acid malabsorption, lactose intolerance, or even the bidirectional link with eating disorders. Before we go, I'd just like to bring in our editor, Pat, to talk about MIMS Learning Live. Hi, Pat.
Hi, Sangeeta, and thanks for letting me squeeze in at the end of the podcast.
No problem. MIMS Learning Live South is next month, right?
Yes, so MIMS Learning Live South in London will open its doors on Friday, 12th of June 2026, giving GPs access to tailored learning to help them achieve even better outcomes for patients. The event is free to attend in person and gives you CPD hours towards your next appraisal, as well as opportunities to ask questions of the speakers and network with other GPs.
Can you tell us a little bit about some of the sessions?
Sure. As you know, this year on MIMS Learning, we're running the Confidence in Obesity Care campaign, highlighting GP's key role in managing obesity and its comorbidities. And I'm delighted to be the host of a discussion panel featuring GP Dr. Patrick Holmes and consultant Dr. Amar Patana from Goggle Docs, looking at what's happening in obesity right now and what the future holds.
Sounds interesting. Another session is going to cover the name change for PCOS that's been in the news, isn't it?
Yes, so the new name for polycystic ovary syndrome is polyendocrine metabolic ovarian syndrome, reflecting the fact that this condition affects much more than just the ovaries. And I'm really pleased we have Dr. Lindsay Thomas coming to speak about this topic at MIMS Learning Live South, and she'll talk about why this condition has been re-evaluated and what the implications are for GPs.
Yeah, that sounds exciting. It'll be great to have Dr. Thomas's expertise at the event. She is very knowledgeable because of her multiple women's health roles, as well as being a GP.
Yeah, and that's just two of the highlights from the event. You can see the whole programme at mimslearninglive.com, and other highlights include an update on the changes to type 2 diabetes guidance, red flag sessions on paediatrics, ECG interpretation and neurological conditions, and lots of other really good stuff. We've got new speakers and chairs to bring you inspiration, and this in-person event helps you to combat isolation and burnout by learning with your peers and getting support through networking. You can effectively create your own event by swapping between streams, depending on the topics that you're interested in. So finally, I said this already, but it's free to attend, and you get a CPD certificate for attending, so what's not to like? You can book your place by following the link in the show notes.
Thanks to all of you for listening into this episode. Links to all the modules we've discussed today will be in the show notes. Don't forget that you can claim CPD credits for listening to this podcast. Head over to mimslearning.co.uk to download your certificate and for links to useful resources and further reading. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Next time, Rhiannon will be speaking to Dr. Michael Blackmore about addiction and GP well-being. See you next time.